Hello and welcome to PCR webinar dedicated to use of drug-coated balloons in coronary bifurcations. This is the third and the last module of Bifurcation Continuum 2025, and the reason to select this topic is that the last couple of years, at every bifurcation session at any meeting in the world, one of the first questions that we receive: can we use DCB for side branch? Can we use DCB in both main branch and the side branch? So we decided to design this webinar and discuss together first what is the available evidence supporting the use of drug-coated balloons for coronary bifurcations. And then we have really expert knowledge to learn how to perform stepwise drug-coated balloon strategy and what is different as compared with hybrid approach combining drug-coated balloons with drug-eluting stents. And of course, technically speaking, the most important part is to understand how to perform vessel preparation, deliver therapy, and how to evaluate immediate result following the use of DCB in coronary bifurcations. My name is Goran Stankovic, and to discuss, we have a fantastic group of colleagues and friends of mine. Bruno Scheller from Germany, Maciej Lesiak here with me in studio from Poland, and virtually connected Hui Chim Tan from Singapore. So, as I said, we will start from the evidence-based, and please use your chat and this unique opportunity in the next 60 minutes to ask absolutely any question related to coronary bifurcation treatment. So I would like to hand over now to my friend Hui Chim Tan.
What I'm going to do is to speak on the topic of what the use of DCB, what's the evidence. I think not every bifurcation lesion is the same, and not every side branch is equally important. A prognostically relevant side branch is one that supplies more than 10% of the myocardial territory. And we can actually tell from the angiography that if the side branch length is more than 73 millimeter, or that you fulfill a Seoul National University hospital score of more than 2, which comprises either a side reference vessel diameter of 2.5, or that there are less than 2 side branches, or there's no side branch below the target side branch, then this is going to be considered a prognostically relevant side branch to protect or intervene in. Now, if you look at the 2024 ESC guidelines for chronic coronary syndrome, the only mention of the use of drug-coated balloon is in the context of in-stent restenosis. And it is said that in the guidelines that the DCB angioplasty and repeat stenting with DES were equally effective and safe in bare metal in-stent restenosis. However, DCB angioplasty was less effective than repeat paclitaxel DES in treating DES ISR. Both drug-coated balloon and DES were more effective than POBA, and everolimus DES was associated with better long-term outcomes than drug-coated balloon. So there was no mention of bifurcation lesion use of DCB, but yet when you look at the Italian Society of Interventional Cardiology, there was a mention of a use of DCB in the treatment of bifurcation lesions. When you look at the German group and the China expert committee recommendations, you also see that there is a recommendations for the use of DCB in bifurcation lesion. And this is also included in the Singapore guidelines as well for the use of DCB. So what is the advantage of using DCB in bifurcation lesion? I think there's now an increased evidence to suggest to us that DCB may be effective in patients with de novo small and large vessels. And its use in bifurcation lesion is appealing because it is a very straightforward treatment strategy. We actually keep it simple without the need for resorting to a 2-stent bifurcation PCI. And also when you use DCB, the local drug delivery could be applied where stents are not used or desirable. The absence of a stent allows for a preservation of the original coronary anatomy. If you look at some of the summary slides of the registry studies done with DCB for side branch, you find that there are actually quite a number of studies showing that the strategy with DCB for side branch is safe and effective. When you look at the summary of randomized controlled trials with DCB for side branch again, you find that there are studies to suggest that DCB may be better than a POBA, and that the problem with some of these randomized controlled trials is that the DCB used were all very different, and that there were also different protocols with the use of DCB in side branch. But one thing is quite clear, that when you look at the meta-analysis here, looking at the angiographic follow-up of patients who receive side branch versus POBA in the late luminal loss as a angiographic endpoint, you find that DCB is superior to POBA for side branch, such that if you are dealing with a bifurcation lesion and you decide that you want to do a DES approach to the main vessel, but only a DCB for the side branch, perhaps you can use DCB right at the very upfront if there's significant disease of the side branch. One of the latest data that come out is the SCAR registry that was first presented in CRT 2025. When you look at 6,000 over patients between the period of 2021 to 2024, looking at patients who received Preview, specifically drug-coated balloon versus all the other drug-coated balloon, and then looking at patient-level endpoint as well as device-level endpoint. What the SCAR registry tells us that certainly with the use of DCB, there is a equal to high procedural success rate, whether with paclitaxel or the other drug-coated balloon drugs. Another point of this SCAR registry is that paclitaxel-coated balloon remains the most common type of DCB drug being used, 97% of procedure, even though the sirolimus-eluting balloon is available. What we also witnessed in this SCAR registry is that in terms of all-cause mortality, there was no difference between Preview drug-coated balloon and all the other DCB. But numerically, when you look at the incidence of new myocardial infarction and target lesion revascularizations, Preview drug-coated balloon seems to have a better advantage over the other drug-coated balloon. Then we also have this concept of a hybrid PCI, where you potentially can reduce stent burden. When we say stent burden, we refer to the number of stents that is implanted and the length of the stent that is implanted. By having a combination use of DCB and DES, we think of this strategy as perhaps useful in the following scenario: multivessel coronary artery disease, diffuse disease, complex lesions such as bifurcation lesion, CTO, coronary aneurysm, and ataxia, or patients with high bleeding risk or have problem with DAPT compliance, and also young patients with prolonged life expectancy. So one of the earliest strategy study of the hybrid PCI is reported by Shin, and clearly you can see the use of a hybrid approach led to a reduction in major adverse cardiac event at 2 years. And the hybrid approach certainly reduced the stent burden in patients with multivessel PCI. So in EuroPCR this year, when we look at the SCAR registry and specifically looking at the bifurcation lesions of about 1,500 patients, randomized two strategy. One is a hybrid PCI approach of DCB, and the other and DES, and the other one is a DCB only approach, and using Preview drug-coated balloon versus the other drug-coated balloon. And what we saw in the SCAR registry bifurcation subgroup analysis is that the use of Preview drug-coated balloon was found to have a lower target lesion revascularizations compared to the other drug-coated balloon in a hybrid PCI approach, but not a DCB only approach. Similarly, in terms of the incidence of myocardial infarction, the use of Preview DCB was also found to be better than the rest of the other drug-coated balloon in patients who receive hybrid PCI strategy. What is even more interesting is that when you have the DCB and the stent in the same vessel, the Preview drug-coated balloon seems to perform better than the other drug-coated balloon. So how do we use a drug-coated balloon properly? I think the most important message here is that you need optimal lesion preparations. And oftentimes we would like to use a strict standard non-compliant balloon in the vessel to artery balloon ratio of 1:1. Specialty balloon may be necessary to result in a more predictable and uniform predilation if any calcification is present. In-stent restenosis and aggressive predilations using high pressure may be recommended to tackle severe stent under expansions. What it also means is that before you start using drug-coated balloon, which is predominantly a drug delivery system, is that you want to use it as a final step of a PCI when you have a proper lesion preparations performed with a fully expanded balloon of the correct size for the vessel. That is an appropriate management of the calcification. There's no residual stenosis of more than 30% that could impair drug delivery to the vessel and limit the potential of this technology. And you also want to make sure that you only have type A and B dissections and not beyond. So when we talk about type A or type B dissections, good to recap that this refers to dissections that are oftentimes non-flow limiting and with minimal or no persistence of contrast after the dye has cleared. So in conclusion, I think the use of drug-coated balloon appears to be safe and effective in non-left main bifurcation side branch PCI. It is a potential alternative treatment strategy. However, techniques needs to be observed to achieve the best possible result. There is still a positive of a large registry and RCT data confirming the DCB efficacy to DES strategy. And that's because most of the studies now are still quite small and utilizes different DCBs and protocols. Thank you very much.
Thank you very much, Hui Chim. This is really fantastic overview. We have the first question, but I would like to summarize with this SCAR registry data. We have really now large patient population, 1,800 patients with PREVAIL, with 99% procedural success rate and really very low rate of events up to 2 years of follow-up, 7.2%. So reluctance of thinking about use of DCB, I think, is now much lower. I don't know, Bruno, would you like to comment also on that one? I feel really very convinced that with these two publications, now we have a large routine practice with almost 6,000 overall patients treated with very good outcome. We used to put stent. Each time we see dissection, we simply put the stent. How would you comment on this?
I mean, one of the most important messages is that it's really safe to do DCB-only treatment. You have to follow the rules, you have to prepare the lesion, and if you are successful with your lesion preparation, then it's really safe to use only a DCB. You do not have to come back at night, you can sleep at night because there is almost no acute and subacute vessel closure. And that's for me the most important message from this huge data set, supporting that this not only works in the hands of specialists, it works in a broad application in many cath labs.
Fantastic. Hui Chim, the first question for you, I think you know data very well. It's an anonymous colleague asking, how about the use of DCB in non-ST elevation acute coronary syndrome? Plus, is there any difference in results for paclitaxel versus sirolimus in these publications?
I think this is where I said the positive of data comes in. I think we are still very much in need of more data to tell us the safety and the efficacy of drug-coated balloon in patients with acute coronary syndrome. But certainly in the situations where DES or stent is deemed to be undesirable or not suitable, I think at this point in time, a DCB is a feasible alternative to patients with even ACS, despite the lack of data for it.
Thank you. Bruno, maybe we hand over to you. You were part of absolutely every consensus document or ARC document related to drug-coated balloons. Personally, I learned everything I know from your presentations. You attended the last 4 or 5 European Bifurcation Club meetings trying to teach us how to appropriately use DCB for bifurcation. So I don't know anybody better than you to tell us how to do it and how to use it. Please present your slides.
Yeah, thank you very much. It's a great pleasure being invited or having been invited to the European Bifurcation Club in the past. I think if we are talk about use of DCB for bifurcation treatment, we have to look at the different strategies there are. The most common and done by most of the physicians approach is the so-called blended or hybrid approach. This means that we combine drug-eluting stent with drug-coated balloon in the bifurcations. Typically, the main branch is treated with a drug-eluting stent, and the side branch is treated with DCB. And here again, we have two options. Number one is, according to the recommendations of the European Bifurcation Club, we treat first the main branch, implanting a drug-eluting stent, then recross, and then treat the side branch with the DCB. From my personal perspective as a DCB protagonist, I prefer the other option, prepping the main branch, prepping the side branch. If the side branch looks okay after lesion preparation, I deliver my drug and then forget the side branch and finally implant the stent in the main branch and optimize this stent. So we can discuss what's the better option. Then we have this puristic approach, which has been provided by long-term DCB users. This means we prep the main branch, we prep the side branch, we deliver the drug again in the side branch first, and then at the end of the day, if it's appropriate, we deliver the drug in the main branch, and that's it. And then we have a very specific situation if you have smaller side branches and the disease is focused on the ostium of the side branch. Then there may be a way to deliver the drug only in the main branch, trust in late lumen enlargement, which also increases the ostium of the branch.
Can I ask you to join me here? Because I'd like to understand personally, because I'm going to be asked, I'm sure, at every meeting following this webinar, how to properly use it. So we start with option number one, which is hybrid approach. Most frequently, probably, people will today use this approach. So we wire both branches. Then we have to decide whether we go with stent in the main branch or we go with preparation and DCB in the side branch. What would you recommend? Which strategy for what kind of lesion complexity? I guess if lesion is not too complex in the side branch, then you prepare the lesion, deliver drug, and then you focus on the main vessel stenting, and then you implant stent and simple POBA in this area here will open access into the side branch, and there is no need to do kissing. Am I right, or
yes,
I'm missing a point?
So my basic recommendation, independent what you do at the end, is really to prep both branches first. You get a feeling how the artery behaves, and if you decide to first implant the stent in the main branch, you already made a better access for the side branch if you have to recross that.
Yeah.
So that's number one, what I would.
Sure. Lesion preparation is the key. I have to ask, because I was asked many times. We do it with NC balloons, we do it with cutting, scoring. We need imaging for that. How do we select? How do we evaluate one-to-one with reference diameter? Please share some tips and tricks.
So I started, of course, with semi-compliant balloons in the past, and I'm still doing this at least at a smaller size if I have the feeling that I have to pave the way for specialty balloons. But my feeling is that in most of the cases we should, in any way, specialty balloons in a one-to-one sizing.
Okay.
And then if you have more soft lesions, I think scoring balloons could be appropriate. If you have moderate calcification, cutting balloons are my first choice. And if you have severe calcification, you have to use all the tools, rotational atherectomy, IVL, whatever to...
So even in more severe calcification, you will consider DCB use?
Yes, if you are successful in calcium modification. You have to create microchannels that the drug can go to the deeper wall.
Yeah, this is the key. What I learned is that DCB inflation is just like painting the wall.
Yeah.
You really need to do all the work before, make it really clean, and then just deliver drug. And so unless you dissect, how do I dissect? How much can I dissect and still deliver drug?
So that's one of the most important lessons we learned in the past few months. We have to dissect aggressively. We have to find the right vessel size, that we do not create flow-limiting dissections, but we have to dissect at best up to the media, because then we have a much better drug intake, and we have enough data meanwhile that show us that late lumen loss is less with more dissection. at least for paclitaxel coated balloons.
Yeah, for me it's very difficult to remember dissection type A, B, C, D. Can you just simplify for lay people like me how to decide when predilatation with dissection is acceptable and when it's dangerous to continue?
So, I mean, we have this old classification, A, B, C, and so on. And I mean, it's helpful as a starting point. But I'm not sure if this is still appropriate for what we are doing nowadays with our specialty balloons, with our different approaches, with the help of imaging and physiology. So I think we have to go back and think about our classification for dissections.
Imaging and physiology, I think it's very important. How frequently you will use imaging? Is it something that is routine or in complex lesions? If we speak non-left main bifurcations.
Yeah. So I mean, if you plan with a stent strategy, you should do imaging. I think that's for sure. If you are thinking about a puristic DCB only approach in, let's say, simple bifurcations,
that's option 2.
I don't think it's mandatory. But if you have more complex lesions, if you are dealing with calcification and all these things, then imaging makes a lot of sense also in combination with DCB.
So option 1 is stenting, as we do according to European Bifurcation Club, select stent according to distal diameter and perform POT. Ideally, and I see here this balloon, we should first focus on the side branch. We try to prepare lesion, deliver drug, and our suggestion is for most of the cases to go this way, or it's for you equally if we first deliver stent in the main vessel and then cross into the side branch. How much truth is actually in this recrossing, stent deformation, stripping of the polymer and losing some drug? What is your experience? I know there is not one single answer.
Yeah, because you gave the answer. We do not know this exactly. I think expert opinion, meanwhile, is if you do recrossing with DCB, do a first predilatation before you cross with the DCB, that you have a wider open.
So with nice NC balloon, you predilate, you create space, and then you cross. Yeah. Any difference between paclitaxel and sirolimus?
In this situation, I don't think that there's a difference, because we have to be aware that most of the drug is within the folds of the balloon.
Okay.
If the balloon is folded, then and if you have a clean recrossing without resistance, I think it doesn't matter what drug you're using.
For puristic, leave nothing behind, I think this is something that you taught us and we accepted for Euro Bifurcation Club DCB trial, this strategy. Because I like the explanation that was used by David Hildig-Smith. If we are good in POBA, and in this image you can clearly see predilate main, predilate side, deliver drug in the side, deliver drug in the main. If we are good in that, can you imagine that today somebody comes with innovation drug-eluting stent, and he tells you, okay, you do good POBA, but now you can put stent in the main vessel, smaller diameter distally, then you take additional balloon, post-dilate proximally, then you recross with the wire, predilate, do kissing, do final pot, and this is good result. What would you say on that?
Yeah, I mean, the history is completely different. That's what we know. But of course, if you are doing this on a frequent basis, this puristic approach, bifurcations are a really simple procedure. That's
no kissing. Yes. No carina shift.
Normally, you have little carina shift if you do not use a too big balloon in the side branch. Okay. That's important.
So this is important. The size of the balloon in the side should not be oversized.
So in this situation, I would say sometimes 0.8 to 1 is also enough. You don't need 1 to 1 in
Perfect.
In this situation. And it's only a sequential use. Predilatation, drug delivery.
Drug delivery, and that's it.
That's it.
Any need for imaging, physiology, only if flow is not good? Huh?
If flow is not good, or if you really have complex disease, as in all other situations, imaging makes sense.
Perfect. And the last option is from Korea, from Prof. Chin,
Yeah.
with really nice OCT demonstration that in small side branches, when you deliver drug, with time you have enlargement
Yeah.
in the lumen.
Because
of the
if
side
you
branch.
imagine that the artery goes like this, you can also imagine that the hole goes like this. And
In
that's,
the
that's the
other
reason why you can do this really in this specific situation. Yeah.
Thank you. This is fantastic. I just want to share that in different anatomies, of course, if there is no disease in the side branch, you prepare main vessel and you deliver drug in the main vessel without performing routine kissing. And if it's 001, then of course, I would suggest to use imaging and evaluate. We know that plaque always grows in the lateral wall, but also goes in the main vessel. So if we see angiographic disease at the ostium of the side branch, I think it's good for planning procedure to evaluate with imaging and then predilate. Experienced people say to predilate with cutting or scoring because there is a lot of fibrotic tissue here. Evaluate with imaging, deliver drug, and make sure that you don't have contrast staining and stop if flow is not impaired. What are the criteria? When would you stop?
In general, number one is flow. If the flow is good,
Dimitri?
then you have 80% of what you will know. And then the true lumen has to be clearly bigger, much bigger than a false lumen or dissection you can see. And it has to be stable over time. And you have to check it in at least 2 angiographic projections.
2 different projections.
Yeah.
Okay. Can you show your case? And now we go to a real world. And one of the cases done in your lab.
Yeah. So this is a patient, relatively young, 69-year-old. He had impaired left ventricular function. He was or is at high bleeding risk with atrial fibrillation, and he has chronic obstructive lung disease. So we decided in the heart team, because of his high surgical risk, first to treat his high-grade mitral insufficiency 1 month ago with TEER, with implantation of 2 Pascal, what you can see here, with a nice result. And then he was scheduled last week for treatment of his known coronary 2-vessel disease. He had in the past stent implantation in a diagonal branch in the LAD, but this was not connected to the bifurcation. It was a little bit more distal. And this procedure was not done by myself. It was done by my colleague Davor Vukadinovic from our hospital. So this is the right, some diffuse DC, but no high-grade stenosis. And here you can see very nicely this bifurcation from the LAD and the diagonal.
Can we stop at this point? Because as someone from the European Bifurcation Club, when I see this bifurcation, okay, it's Medina probably 1011, or there is clearly diffuse disease here, a long segment proximally. This is my interpretation. In my view, this is the lesion that we have. I don't have imaging now, but Maciej, what do you think? What would you do in the lesion like this one?
Yeah, it can be treated in both strategies. I would start perhaps with provisional because the length of the here I think you a little bit overestimated the length of the lesion in the side branch. Yeah. In the side branch. So because you still can treat, if we are talking about stents, of course, you can still treat the main vessel and the side branch if needed, but of course the proximal part maybe it's not severely or significantly stenosed, but generally we know that the lesion is diffuse, so using a drug-coated balloon is not a bad option here. Provided, of course, the result of the very, good preparation is optimal.
So, okay, I can share my perspective. DES with provisional and probably for diagonal DCB. I really like not to predilate, so I have to defend the EBC approach, focus on the LAD, do POT, and after POT recross, prepare diagonal, and deliver drug.
Or differently, so as already Bruno mentioned, that if you are convinced that you want to treat the side branch anyhow, then you can start with delivering the, of course, preparation, then delivering the drug to the side branch, and then you do just, optimal main vessel stenting with POT and no kissing at all, yeah?
Yeah.
No recrossing, no kissing.
I said this is a little bit biased because, I'm absolutely convinced that in this relatively diffusely diseased, I know that stent is probably somewhere here, in this diffusely diseased neointima, sometimes you can create dissection, increase the risk for stenting. But of course, now with this small undersizing and with cutting or scoring, a risk for that is really lower and lower.
We have data from Manuel Pan's
From
study
Manuel Pan, yeah.
when they found that there is no influence on the clinical outcomes, but the recrossing is easier, you spend less time, less contrast.
And he published that in American Heart Journal 15 years ago, and we still keep working in the same way. Let's see what the experts do. What Davor and yourself decided to do in this case?
So great. We opted, of course, for our puristic approach first, or we started, as mentioned before, with wiring both branches, predilatation of the main branch, predilatation of the side branch, and we had a 2.5 balloon only because it looked, especially the ostium of the side branch looked very tight, so that we wanted to create first a reasonable lumen. And on the left you can see now what was the result. And I mean, there is still, this is not a really good result. We have still areas that are not really good, improved in the lumen. And so, but we have seen here that the vessel responds okay if you do angioplasty in both directions. We have no signs of a relevant carina shift here. And so he decided to go further with another round of vessel preparation of the side and the main branch.
As you described previously.
Yes.
So you go stepwise.
Stepwise, but this was now the time to go with a specialty balloon. And since there was not that much calcification, we opted for the scoring balloon in this situation, not for the cutting balloon. And for cost reasons, we used only one device, 3.0, and it was used with low pressure in the origin of the side branch and with higher pressure than in the main branch. This is what you can see on the right. And this was now the result after scoring balloon treatment of both branches.
Good, so no really dissections which impair flow.
Mm-hmm. So if you look very, very closely, you may see a small dissection in the proximal side part of the side branch, but it's for sure it's not a relevant potentially flow-limiting dissection.
Exactly.
So it fulfills the criteria of DCB only. We have diameter stenosis of clearly less than 30% in both branches. We have an excellent flow. We have no major dissections. So the requirements for the use of a DCB are fulfilled in this situation now.
Okay, next step?
Next step, DCB. 3.0 by 20 from the LED to the diagonal. It's fine to have a small part of the balloon in the main branch.
That was my question.
Yeah, because it's smaller, because the main branch is a 3.5.
So the amount of drug that is actually delivered in the main branch is not very high, does not...
It's washed out, more or less.
Yeah, question that we always receive and we need your knowledge. Why not to perform kissing balloon with 2 DCBs?
There are 2 reasons. Number one, you know that as soon as the balloon is in blood, it starts losing track. So and if you use 2 balloons, you have to introduce the first one, park it somewhere, then introduce the second one, then position both. And this is, in most cases, too long, and you will lose too much track on the first one. And the second one is a geometric consideration, because if you have the full track application, if you have a round-shaped balloon, if you have kissing in the proximal part, you have 2 ones with very limited contact to the vessel wall, and you lose more track than you get to the vessel wall. That's the reason why we do not recommend kissing DCB.
Thank you for that. Maciej, any
And also
question?
you increase the possible injury of your proximal because there is no stent there.
There is no stent to
and
protect.
you can dissect the
And there is always
the
partial twisting of the balloons.
course.
It's not
Movement,
just
yeah.
two balloons.
Fully
And so, question.
Let's go back.
People claim that in the first 30 seconds, 80% of drug is delivered.
Yeah.
Is that true?
Yes, not for all DCB. We have different technologies. So those DCB we are working with deliver most of the drugs really in very few seconds. And we have the full effect in the healthy animal model with 10 seconds inflation. But in humans, we have to deal with atherosclerosis, which is some kind of barrier for drug transfer. So from this perspective, it makes sense to do longer inflations. And we know that long balloon inflations also improve the result of your angioplasty. And therefore, it makes sense really to go long, to go at least 30, better 45 or 60 seconds with the DCB.
If hemodynamic status does not allow that, this is the
But
main...
vice versa, if you treat, for example, instant restenosis in the left main and the patient does not tolerate 30 seconds, it's also fine to go with 15 or 20 seconds balloon inflation. You will deliver most of the drug also with this procedure and do not create harm to the patient due to pressure increase.
And then we evaluate the result angiographically, or?
I personally, in this situation, would have been fine with a good angiographic result, but we planned also to present this case today. And
Thank you
therefore,
for that.
Of course, we did some intravascular imaging.
Let's see.
And here you can see the OCT in the LAD. Now we are distal of the treat area. Now we come to the treat area. You see these ugly dissections. It doesn't look nice, and most people would say, oh, you have to stand now. But look at the lumen, at the true lumen. Here's the origin of the diagonal. The true lumen is good in all areas, and the dissection is connected to the wall, and we have no big areas under the dissection. And so that's the criterion by imaging.
Thank you for showing this. This is really very impressive.
Yeah. So and here you can see the OCT from the diagonal back to the LAD. This was the bifurcation. And here again we see the proximal dissections, and you can also nicely see the old stand, which is several millimeters away from the ostium.
Yeah, so ostium is really spared from the metal.
And also here we have some dissection in the proximal diagonal, but it's not flow limiting, and the lumen is okay.
But it's definitely much less on angiography than what we see here.
Yeah, then let's have a look at angiography.
Yeah, let's go to final angio.
And this is the angio. I mean, that looks really good if you look here. And again, it is important, you have to see good lumen, the absence of severe dissections in at least 2 projections, as we did here. And I think it's a nice result. We have a good flow. We have no high-grade dissection, and we have in all parts a good initial lumen gain, which, in my opinion, satisfies this treatment without stent implantation.
Fantastic, and it's definitely big diagonal. Maciej, any comments?
Yeah, another comment is there is no carina shift, never, almost never. Yeah? So you see that the side branch is not compromised. If there is no flow limiting dissection, then there is no major issue which we really fear from during stenting, which is carina shift. Yeah.
Huichin, do you have any comments? This is really fantastic demonstration.
Indeed, I think the results here is stent light with the drug-coated balloon. The challenge has always been to know what is the long-term patency of such a vessel in comparison to the drug-eluting stent. And we know from cage 3 that there was a DCB proving to be non-inferior to DES. So I think the challenge here is really to know what is the long-term results. I just have a comment here as to what sort of antithrombotic regimen should we be giving these patients now. I think he's got NOAC on board for his atrial fibrillation. So how are we going to give antithrombotic therapy for this patient?
So he has antithrombotic therapy with NOAC, lifelong, of course. And in addition, he gets 4 weeks of aspirin. That's it.
I think we have some questions here already in the box. Dr. Fatayr is asking, in case of 001 lesions, do you extend DCB back in the main branch or only we dilate it in the side branch? I think you partially answered.
Yeah.
You go from the main branch. It's not
because
dangerous.
the DCB is typically smaller than the main branch.
Anonymous, can DCB be landed on all kinds of plaque? Are there plaques which DCB would not be suitable strategy to use?
If you are, my personal opinion is, without having the data, is that if you are able to do a good lesion preparation, if it's calcium, if it's thrombus or whatever, if you create an environment where you have a good lumen and the prerequisition for a drug transfer, then you can use the DCB.
It can be also CTO, calcified lesions. If you prepare it well and gain a good lumen, then you can apply drug with DCB and that's it, yeah.
Dr. Cruz, is there penalty for doing final kissing balloon inflation, either for blended or puristic approach? Do we make harm by doing final kissing?
In general, you should avoid it because you create additional mechanical injury in this situation. But if you have, for example, unexpected carina shift after DCB treatment, then you should do it, of course.
Hello, professors. Quiseno is asking Jorge, could preparing atheromatous plaque with intravascular lithotripsy improve the effectiveness of these medicated balloons?
I think it's necessary. If you have 360 degrees calcium, then you should do something to crack the calcium to create channels.
Okay. DCB for osteal LCX, which is usually problematic with DSUs.
Yeah.
Right to the point. You will get case demonstration, not only answer to your question. Unfortunately, it's anonymous.
Yeah, okay, so exactly, this is a kind of lesion nobody likes, and especially in this young lady I present now, 48-year-old, with very severe angina, hypertension, no MI. And this is the anatomy. By the way, right coronary artery was pretty normal. And what you see here is just the isolated osteal lesion in the circ. And what is especially difficult here, maybe let's come to the...
Yeah, let's go to the...
Yeah, that the left main is very, very short. It's like 3 millimeters, and you see there is a tight stenosis at the very ostium of the circ. So it'd be very difficult to position correctly the stent, because of the movement in the IVUS, left main was just 3 millimeters long. Yeah, so with the movement of your heart, it would be very difficult both position at the ostium of the circ or even at the ostium of the left main. Yeah, so that's
even inverted provisional from the left way
could be difficult here, yeah.
Because of the short left main. So what you decide?
Yeah, so we have a couple of options for this kind of anatomy. So we can nail the ostium, and I mentioned that it might be difficult in this particular case, and I will tell a little bit more about this in a minute. Inverted provisional stenting, this is what we recommend as a EBC, because this is very predictable and safe technique. It can be any stent strategy, 2-stent strategy, dedicated stent, or, of course, DCB. So with nailing the circ ostium, there's a big problem because it's not very easy to position properly the stent. And in most of cases, either we are missing the ostium or, as in this case, the stent protrudes into the main vessel, and then after some weeks or months, it's covered with a tissue and may cause the problem like this case. So this is another case, of course, when we try to position very precisely at the ostium of the circumflex stent. You see the implantation, a beautiful acute result, but in no more than 3 months, the patient arrived to our hospital with non-ST elevation MI, and now you can see a very ugly pattern of instant restenosis, comprising also not only CIRC but also left main. If you look at the data, this is the large trial registry, clinical outcomes of PCI according to bifurcation Medina classification, and you can appreciate that actually the Medina 001 lesion correlates with the worst outcomes, both of TLF, cardiac death, and cardiac cardiac lesion revascularization. So this is really a difficult to treat lesion with poor long-term outcomes. So now we come back to let's come back to the case. So you see IVUS. This is mostly fibrofatty tissue. So we did IVUS just to prepare the lesion with good tool to obtain good results. So you see the significant, very short fibrofatty tissue in the ostium of the circ. So we started with pre-dilatation with NC balloon 275 by 12. By the way, upon IVUS, we knew that the reference vessel diameter is 3.0. Then after that, we applied the cutting balloon, multiple inflations with very satisfactory angiographic result, 3.0 over 12. And this is the moment, if you obtain a good result, good flow, no flow-limiting dissection, to apply the drug. So just drug-eluting balloon only to apply the drug.
So wire to protect LAD and then minimal protrusion inside the left main.
Yes, but of course the protrusion has to be some protrusion, and the left main is always much bigger than the reference diameter of the side branch, which is here a circ. So we don't touch the wall of the left main in most of cases. So application of the drug, and you see very nice, almost again stent-like result with no carina shift towards the left main. And this was, of course, also confirmed by IVUS. Imaging never looks beautiful after ballooning.
Yeah, we realized before.
Yeah, OCT or IVUS, but you see the lumen is quite nice. I was happy to do this case during our workshop in Pune with my colleague, Dr. Badani. So thank you very much for this case. And I know that the patient is doing well after a couple of months.
Fantastic. Some more questions we received. What is the percentage of imaging in these large-scale registries with DCB? If I remember, Hui-Chim, it was 22-23% in SCAR registry.
Yeah, it's probably close to that.
Yeah, so it's 1 out of 5. Maybe we need also to think to increase. Then there is another important question. Is there any reason to bring patient back for follow-up angio in 3 to 4 months? This was the question. I'll try to locate it.
I don't think so. If the patient is doing well, I wouldn't just invite the patient for angio. The same what we do with stents. Yeah, if the patient is doing well, if the vessel did not, didn't collapse during the first hours, it's almost never happened later.
Perfect. I think this one is for Prof. Scheller. For DCB preparation, in case of more than type B dissection, any data about shredding the dissection with cutting or scoring, then applying DCB instead of stent?
Yeah, there's a very nice paper from Professor Shin from Korea again.
Yes.
She looked at it if you use scoring balloon versus non-specialty balloons, and the incidence of type C dissections was significantly lower. The initial lumen gain was much better than if you use it, and also the number of potentially flow-limiting dissections was significantly decreased. So it makes a lot of sense to use specialty balloons. I mean, even if you have, after semi-compliant balloons, you see sometimes ugly dissections because you have big parachutes that are in the vessel wall, and you can cut all these things in a very elegant and controlled manner if you are using scoring balloons.
Is there imaging then mandatory part to guide procedure, or you rely again on angiographic appearance?
I mean, we are learning that imaging is very well suited to plan your procedure and to define the real vessel size, to get the right one-to-one sizing. I think that's something angio cannot do in most of the cases. But the decision at the end to cross over from angioplasty to stenting should not be based by intravascular imaging at this time, as long as we have no criteria for it.
And criteria for bailout, residual lesion or dissection?
Criteria for bailout are
flow less than 3.
Flow less than 3. High-grade elastic recoil if you do not manage to get a reasonable lumen with your angioplasty, and dissections that change their appearance during your procedure, and a false lumen that comes to the true lumen in terms of size. Those are the criteria to cross
And
over.
in experienced hands, what percentage of cases is ended up with stenting? 10%?
In our lab is about 20% on a per lesion basis, but this means that about 50% of the patients or more have hybrid procedures. So one stent for a difficult lesion and DCB for longer diffuse areas.
Maybe just a short comment about what do you mean a bailout? Because for me, bailout is if you apply the drug balloon and then the vessel collapses or we have dissection. Because stenting after very aggressive predilatation is just a part of the procedure. I wouldn't call it bailout because this is what you expect in, as you mentioned, between 10 and 20% of cases. Real bailout is you have a good result, you decide to just deliver the drug, and then you see that the flow is worsening.
Decreased flow,
Then you have to use a bailout stenting. Yeah.
Good. Can you please tell again why we should not do kissing balloon inflation in DCB-only treatment? No, Dr. Baraccotti, we did not say you should not do it. There is no need to routinely do it because with DCB only, the amount of carina shift is really very low, so there is no need to traumatize with simultaneous inflation and correct the position of carina. But thank you for that question, it's very important. Which DCB is better, paclitaxel or sirolimus? This is for the expert.
So we have differences in the drugs. The big advantage of paclitaxel is that it has an irreversible binding to the microtube. So if it is in the cell, it stays there. Limus has a reversible binding with the mTOR receptor complex. And that means if you want to create a DCB that is similar efficacious as a paclitaxel DCB, you have to guarantee for long persistence of the drug in the vessel wall and in the release from this deposit you create. And that's technically much more challenging than with paclitaxel. So we will see the data soon from the large Limus trials, and then we may have an answer to it.
Yeah, with really positive results in registries and with help of yourself, Prof. Kleber, Simon Eccleston, you really helped European Bifurcation Club to design together. This is joint effort. European Bifurcation Club randomized trial, stepwise provisional stenting versus drug-coated balloon therapy for non-left main true bifurcation lesions. I got these slides with courtesy of our PI, Dr. David Hildig-Smith. So this will be 750 patient study, 1-to-1 randomization, puristic DCB, stepwise DCB, versus stepwise provisional according to European Bifurcation Club recommendations. With good data from SCAR, also from other registries, we selected to use Prevail as DCB platform, and from EBC main we use Onyx as platform for drug-eluting stent arm. 6 to 8 countries, approximately 20 sites. These are the countries: UK, Germany, Italy, France, Serbia. I'm very happy to be part with 2 other centers in this trial. Our hypothesis is that drug-coated balloon therapy will be non-inferior to provisional drug-eluting stent implantation for non-left main true coronary bifurcations, with the objective to investigate clinical outcome following stepwise DCB versus stepwise provisional DES strategy in non-left main lesions for now. Primary endpoint is clinical, 1-year bifurcation-oriented composite endpoint, which is composite of cardiovascular death, target bifurcation-related MI, and target bifurcation revascularization. And just to repeat, stepwise DCB strategy, wire both branches, 1-to-1 predilatation, preparation of the main vessel. If we achieve acceptable result, then predilatation and preparation of the side branch. If result is acceptable, 1-to-1 DCB in the side branch, 1-to-1 DCB in the main branch, and this is stepwise DCB. I think everybody knows EBC approach to stepwise DES, and this is the trial scheme, and it's very important that we will follow these patients up to 8 years, because really the longer the follow-up, the benefit of pure DCB strategy is expected to be higher. Initially, this is a non-inferiority study, but if we reach non-inferiority, we are powered to do also superiority analysis. And I really believe that this will be practice-changing for coronary bifurcation treatment. A few more questions. Dr. Ruati, can we inflate 3 times 20 seconds in the left main?
Those DCB that I'm aware of from the technology side have no drug anymore after the first 20-second inflation. Then you can do POBA inflations again. But that's all.
The most important is the first one. Yeah. For side branch DCB PCI, how much of the balloon may be allowed to protrude in the main branch? Doesn't matter.
Just be sure to cover the ostium, so there must be protrusion. And
to deliver drug at the ostium.
Due to fractal geometry, the balloon diameter will be almost smaller than the proximal main vessel, yes? So don't worry about proximal main vessel. Yeah.
For how long DAPT in DCB only cases? Both for acute coronary syndrome and for chronic. What is the position of DCB consensus group?
So acute coronary syndrome, according to the guidelines, 1 year at this time. If you do not implant a new stent in stable patients for weeks, and the next step will be how to deal with high bleeding risk patients, and this may end up in single antiplatelet therapy, but this is under investigation now.
Perfect. Dr. Grigorov, does DCB, oops, it disappeared, sorry. Something happens with this. Could you please again summarize on the balloon for preparation? Scoring, if, whatever. How to do preparation? Scoring 1-to-1.
Scoring 1-to-1, cutting 1-to-1, NC 1-to-1, semi-compliant in doubt a little bit smaller.
This is
so we should prepare, we should use aggressive yet safe preparation. Cutting or scoring, which does, the cuts, facilitates the drug penetration, and in the same time is safer than just regular balloon. Yeah?
Does DCB only approach mean more contrast and X-ray time, Dr. Grigorov?
No.
No. Simple answer. Professors, can we use GLP-1 analogs to improve endothelial response to DCB?
I mean, that's a general, very interesting question. If we cage a vessel, then systemic secondary prevention has no access to this local place anymore. If we do not implant a permanent implant, we still should have access for secondary prevention. I think, and that's very important, because this could be one of the major advantages of this therapy.
Thanks. A very nice question, again anonymous. Maciej, maybe for you, in case of imaging post-DCB, would it be safer to use IVUS rather than OCT in the presence of dissection, even if it's non-flow limiting?
I think if you do it properly, I don't see any issue with OCT. So you can do OCT also, not too many injections. When I perform OCT, I never then after OCT inject again for just angiography, because this is, you know, you have more than enough data from OCT than from angiography. So you can limit the number of injections with OCT.
The last question that we will touch today, technical. What is the definition of optimal lesion preparation before application of DCB?
So the consensus group recommendation, a pure expert opinion, was TIMI-3 flow, diameter stenosis less than 30%, and the absence of a flow-limiting dissection. This is pure expert opinion, but has been used in most of the trials, and this means it makes sense to do so. But in the future, we maybe have more differentiated approaches to
Thank you very much. Thank you for coming. I feel so relaxed, you know. I just shift questions in this direction. Expert opinion needed. And was really great pleasure to have you both. Thank you very much. Hui-Chin, thank you so much for this excellent presentation and excellent comments. And thank you for questions. I'm sorry that we were not able to answer absolutely everything. Many were repetitive, so I did not repeat questions, but I hope that we were able to answer at least the most important ones related to strategy and then to actual procedure, lesion preparation and drug delivery. So I would like to thank, of course, Medtronic for again supporting this series of bifurcation webinars in 2025. I hope we will continue collaboration in 2026. To all of you, I wish you a nice summer and hope to see you back sometime in September or October. Thank you very much for helping us to create this great webinar. Thanks.
Thank you.